Hello, everyone. This is Michael Durham. I'm the Technical Assistance Manager here at the National Healthcare for the Homeless Council. And I'm really glad to join you today for this conversation about anti-racism and COVID-19 response. It is the Tuesday after Memorial Day. I'm completely disoriented with the time and this Tuesday feeling like a Monday. But I did put on a shirt with buttons today, so that's weird for quarantine. But I'm so excited to be with you guys today. There's a handful of things I need to tell you before we get started. The first is this is an edition of our Coffee Chat series, and we call them Coffee Chats because they're meant to be informal discussions, and really our goal for today is for you to take a breath from the chaos and talk to one another. The chat box that you see on your screen is meant for you to talk, to introduce yourself and talk to each other throughout the presentation, and you can also ask questions of our panelists there. So grab your coffee, I've got mine, and let's talk about racism. Just a couple housekeeping things here. We are recording, and we'll post the recording on our website in a few days. And if you're having any technical difficulties, you can use the chat box to let us know about those, but you could also call Caroline at 615-200-6165. And this presentation is supported by HRSA. So that's important for me to tell you. So I want to just briefly introduce our panelists and moderators today, and then we'll get into a poll so we can hear a little bit from one another. So I'm so excited to present to you Tanya DeJoyos, who is the Chief People Officer at National Health Foundation in LA. Chantel Lewis is the VP of Equity, Inclusion, and Diversity at Colorado Coalition for the Homeless in Denver. Renata Robinson works with Chantel as the Chief Human Resources Officer. Linda Sunstone is the CEO of First Nations Community Health Source in Albuquerque. And Sonia Spears is the Chief Equity and Inclusion Officer at Boston Healthcare for the Homeless Program. So I'm so excited to see all of you guys. And I'm Michael, as I said, and I'm going to be joined in a moment by my colleague Lauren, who is also based here in Nashville. So let's hear from you guys. I've got two poll questions, and I'll ask my colleague Brandon to put up the first one. What kind of organization are you guys joining us from? And thank you guys for introducing yourselves in the chat. It's good to see you. So our options here are the first one, a Healthcare for the Homeless program. Maybe you're at some other kind of health center or healthcare provider, like a medical respite program. Maybe you're working at a new alternate care site or an isolation and quarantine facility. Is that open yet? There we go. Maybe you work for a shelter or some other sort of homeless service provider that gets COC money. Maybe you work for a local government or some other public entity. And maybe you're in advocacy or policy legal. And some of you may work for both. You could work for a public health care for the homeless program. So just choose the truest option for you. I'll let that stay open for a little bit. We've got a really good mix. Folks from COCs and healthcare for the homeless. Great. All right, yeah, we can go ahead and close that, Brandon. Now here's a slightly different kind of question. Tell me how much, or to what extent you agree with this statement. My organization has been conscious, proactive, and consistent about racial equity during this COVID-19 pandemic. And panelists, if you want to respond to the poll too, that's fine with me. So far, most folks are choosing agree, which is interesting. Yes, no middle option. I don't know that neutral is a satisfactory response, but I know there's differences of opinion on that. All right, let's go ahead and close that. Thank you, Brandon. All right. So I just want to say a few words about what brings us to this topic and this conversation today, and then I'm going to turn it over to my colleague Lauren to show you a new thing that we made on our website. So I think this should be no surprise to all of you, but really the racism that is endemic to our culture is just showing itself in ways that are perhaps not as normal in non-pandemic times. We're seeing the discrimination, particularly among Asian Americans, with a racist connection of the virus to China. And really, those of us who are already most vulnerable to injustice are just experiencing that in the extreme right now. And as many have opined, really the pandemic is exacerbating all of the underlying injustices of our country that were already there. And just the thing that we've noticed, I didn't say at the top that we've hosted a couple of learning collaboratives, is what we call them, on diversity, equity, and inclusion over the last couple of years, which has been a really incredible way to learn from the community that we're serving about our different strategies institutionally to really pursue racial justice. And in these learning collaboratives, it's become apparent that our organizations are tending to shelve racial justice work, that a lot of it is being put on the back burner. Not all of it, but that has been a tendency at some organizations. So it was actually a little bit surprised to see how many folks agreed with that statement about retaining a focus on racial justice in our organizations right now. But the point is, if it wasn't really a priority before a pandemic, then it never really was. Or if it isn't now, it never really was. The panelists here, most of us come from these learning collaboratives that I alluded to, and so I want to pull some of the lessons learned from that to inform our conversation today. So that's why we're talking about this. And with that, I'm going to pass the mic over to my colleague Lauren, who is not on the screen, to talk about a new tool that we've developed.
Thanks, Michael. So I just wanted to briefly take a moment to bring everyone's attention to our new COVID-19 dashboard, which you can access from our COVID-19 page linked in the resource pod on the bottom of your screen. So this data is going to be updated weekly. Some of this is going back to April 24th, some of it earlier than that. And it includes information from HRSA-funded health centers. So we have national comparative data as well as charts showing testing and positivity rates by race and ethnicity available. I wanted to quickly call out one disparity that is noticeable in this data, and that is testing rates by race, and that's what's on the screen here. So what we've seen is that consistently about 20% of folks who are tested for COVID-19 at HRSA-funded health centers and Healthcare for the Homeless specifically identify as African American. And that's about half of the homeless population, where we see an overrepresentation of people of color. The homeless population in the U.S. as of last year was about 40% African American. So we're not testing the folks that are representative of our population. I don't want to take a ton of time just because I think this conversation is going to be really important. But before I hand it back over, I do want to mention that there are a couple limitations to this since it is just representative of health centers. Not all health centers are reporting weekly, so it really just is a helpful snapshot, not necessarily the whole picture. So what you're seeing in your community may be a little bit different. And we're going to keep tracking this week by week, and we encourage you to use it as a resource to identify other disparities nationally or compare it to what you're seeing in your community. Using this data and other data can be a really great way to help make a case for action and changes in your community. But I do want to say that collecting information is really just the first step and not an action in and of itself. So I'm really looking forward to the conversation today to hear more about what that can look like and how you can use some of this information to support the changes and actions that our panel are going to talk about. So thank you so much. I'm going to hand it back over.
Thank you so much, Lauren. Lauren, you put a lot of work into this, and it's a really exciting tool, and I appreciate what you said about the limitations of it, even as useful as it is. So thank you for that. So I've asked all of our panelists to prepare just one slide to tell us a little bit about your experiences in your own organizations as it relates to racial justice. And so first up, we're going to have my friend Tanya in LA.
Hello. Good morning. Thank you all for being here. I appreciate it, the opportunity to share with everyone. So my name is Tanya de Hoyos. I am the Chief People Officer for the National Health Foundation. We do recuperative care centers, but we act on the social determinants of health here in LA. That looks a lot of different ways, but one of the main ways is with housing. And so we have recuperative care centers here in LA. We have 2 within LA and 1 in Ventura, so a little up north. And just recently, we've teamed up with Project Room Key, which is in response to LA's homeless crisis, to put, the mayor has acknowledged and committed 15,000 beds to try in an effort to COVID response to get people off the streets. And so we helped team up with the city and county to open up a shelter. So it is a 92-bed facility that just opened last week. So very, very exciting, and well, it is definitely JEDI in action for us, because working with the city and county and FEMA all together really puts our values to the test, making sure that, you know, we push through with our values and making sure our guests and our staff are taken care of. So when asked to be on the panel, I really tried to, for me, when I was thinking about JEDI, and we call it JEDI, it's Justice, Equity, Diversity, Inclusion, it's, you know, DEI. But for us, when I started really thinking about what we were doing as an organization, immediately for me, and this is just how our organization runs, we're a smaller organization, our leadership team is very committed to JEDI, and for us, you know, JEDI is woven into our values, and that hasn't happened overnight at all, but we place a great deal of emphasis on that. And our leadership team puts a lot of value on that. So honestly, when the crisis first started, and, you know, I'm talking like early March, which seems like an eternity ago, and really such a few, you know, short weeks ago. For us, our first concern was our staff. And so, you know, when I think about diversity work, right, and we are very, very committed to hiring from our community, and within LA, you know, we have a very diverse community here. And so when we're hiring from the community, and we are absolutely committed to having diversity of thought and just different backgrounds, my staff is, you know, 75% Black, Indigenous, people of color. So when thinking about response, I don't have to think about the community as like a foreign concept, like we have to help the community. Well, the community works for me. Like, we are the community. And so we have to take care of our community first. And so that was really, really important as a leadership team. That was like the first things that we thought about. And so some of these, you know, some of the things on my slide, and actually a little bit of it got cut off, it seemed very small, but I feel for the welfare of our staff just hands down feel very, very supported. And, you know, we keep on doing surveys. We do surveys every 2 weeks with our staff besides one-on-ones, just asking them, what do you need? How are you feeling right now? How can I support you? And I think that's critical because we have to serve our guests, and we have to serve our centers. And how can we serve our centers if our own staff don't feel valued and supported? And so that's what we went with first. That was like, okay, what can we do? Some of us, had the privilege of working from home. And then, that's actually a small percent of my employees, because the rest of my employees are, working in our centers. They are essential staff. So, we really, it was not easy at all, but thinking, okay, how do we make this equitable? Some of us get to work from home and have that luxury, and some of us do not. So how do we make that equitable? And our first, thought was crisis pay, right? I'm asking you to go out there. I'm asking you every day to leave the comfort of your home and to go to work. And so to make that equitable, crisis pay was definitely put up and voted on, and, that was one of the first things that we felt like our staff needed. And we were going to make it happen one way or the other. So crisis pay was first. Sick time flexibility. So initially, before Families First Act came out, we realized, again, like asking our staff what we felt, some of their fears were. And a lot of their fears were like, what if I get sick? What if my kids get sick? Oh, school is closing. What am I going to do, right? And so, again, just trying to address the issues that our staff were facing. And so we made it, you know what, there's a lot of flexibility with our sick time. We're already pretty generous with our sick time. We give 96 hours of sick time on top of vacation, but I wanted to make sure, hey, if you're in the, if you're edging towards the negative, that I'm going to let you go into the negative, and we'll work it out. And, we're going to make sure that, we give you flexibility for how to use that. You don't have to, we also make sure, again, just emphasizing to our employees that if they are sick, they can stay home, and that's okay, and we're going to find a temp. A lot of our employees have this sense of, I can't leave now, it's crisis, right? And so saying to them, I value you and I thank you, and our guests thank you too, but, we really need you to stay home because we care about you in the long run, and it's okay. And, we'll pick up and we'll have a temp and everything will be okay, right? So we also realized that a lot of our staff utilize public transportation and to get to work every single day. And in LA, their public transportation is used a lot here. And so immediately once, all the reports started coming in about how, you didn't want to be in groups of 10 or more and all that kind of stuff in the beginning. And we really didn't know, initially what it was all about. We were getting dribs and drabs of information, but trying to make decisions on those dribs and drabs of information was going to be critical. So, again, trying to do it through an equity lens, So there's some of our staff who can, shift and bring their car to work. And then there's our staff who just don't have the resources to be able to do that. And so that's when we already used Uber transportation for our guests when they have to use, when they have to get to doctor's appointments and things like that. So we did that as well. We offered up Uber credits to our staff who use public transportation solely, again, so that they wouldn't have to have that risk. Try to make it as equitable as possible for them. In the beginning, there were supermarket lines and, food scarcity, really in the beginning. And so we said, you know what, honestly, I don't want someone having to what people were doing that we heard through the grapevine is people weren't eating, right, to leave food for their kids at home, right? So we're like, okay, that should not have to be a worry for you, right? You should be fed here on staff, right? We already have, lunch programs for our guests. We'll just up the order a little while you're here and provide that for them. Food scarcity then didn't become such an issue, and you know, as soon as we were having conversations with our guests and our staff and say, hey, is this something you need anymore? And they're like, no, we're okay, thank you. So again, I emphasize for us, a lot of what we were doing was truly having conversations with our staff at all times, like really open communication, and our staff was just so hungry for that. And I feel that how that plays, I guess, into equity work is that, you know, when my staff who live in our communities, who are our communities, are telling me that there is disparity for them in their neighborhoods, then whatever we can do as employers is what we have to do. And so that was, if it's conversations, mental health, that's what, unfortunately that cut off on the slide, but prioritization of mental health. We just asked our staff, what do you need, you know? And they said, you know, breaks, meditation. I run a meditation night every Thursday night, open Zoom call. Anybody who wants to drop in and just show up for 15 minutes, I run guided meditation. Sometimes it's 10 people, sometimes it's 1, but I'm like, if you need it, I'm here. So I think, honestly, just having an open conversation with our staff about what it is their needs are. And, you know, I think for us, you know, diversity work isn't something on a paper. It's really like has to be ingrained in our culture, and we're a diverse staff. And so immediately, you know, this is where I think the rubber meets the road. You really need to, for us, it was, you know, values in action, doing it for our staff first. That's where we began. So.
Thank you so much, Tanya.
Of course.
I'm sorry your slide got cut off there. I didn't know that until you said it. So Sonia in Boston, we're going to hear from you next. Excited to hear what you guys have been doing.
All right. So hi, everybody. Thanks again for the invitation. So the Boston Healthcare for the Homeless program, just quickly for those of you that might not be familiar, we focus on primary care. We have respite care as well. We'll offer behavioral health services, dental services, pediatric care. We have a women's health clinic that meets on a Saturday, well, used to meet before the pandemic, and an immigrant health clinic, which was just getting into full swing before the pandemic. We also have a transgender program, and we generally see approximately between 11,000 and 12,000 patients every year, and we have a staff of close to 600. And we have a main hub where most of our offices are, and then we are also spread out throughout the city of Boston. And we have clinics at different partner shelters around the city of Boston. And so that's kind of how we reach folks. And so one of the first things that when the pandemic started, our Equity and Social Justice Committee, this was when we were realizing early on, I think this was somewhere in February, the things that we started to hear were about the racism that Asian Americans and Asian heritage folks were experiencing. And so our Equity and Social Justice Committee hosted a brown bag seminar where we discussed this, and in fact it was called Pandemic, Panic, and Prejudice. And so at the very beginning, we spent a little bit over an hour discussing this with staff who wanted to come. And when we have these events, they're usually self-selected, so people who want to will show up, and people who are able to show up during the workday. And we also do them during the workday as well. And we had probably about 20-something folks who attended. But I think that was important to set the stage. Once the pandemic got underway, though, and things started to go really, really quickly, and let me just say, because I think it's important for me to note here, that my job is mostly staff-focused and not as much patient-focused, just so that folks know. But once the pandemic got underway, our program started to mobilize at lightning speed with members of the city, with the mayor, with the governor, with all of these city partners, to figure out how to stand up different shelters and different COVID care spots. And so within the first few weeks, we erected a tent, which was close to, which was on one of our properties, or right next to the site of one of our site locations. And that was a tent dedicated to COVID care, where we put 35 beds in. And then there was an abandoned hospital that our folks talked to the different folks at the Department of Public Health and the city leaders to open up an additional 35 beds there for folks who were waiting on their COVID results and also for COVID care. And then in the city of Boston, our convention center was transformed in similar ways to the way that they did it in New York, where they set up 1,000 beds for COVID-positive folks, and 500 of those beds were set aside strictly for people who were experiencing homelessness or who were marginally housed, or who, for whatever reason, could not recover safely, or they couldn't self-isolate, or if they had symptoms, maybe people who were living in multi-generational housing, whoever needed it could stay in those 500 beds. And so our program managed that side of the convention center. They called it Boston Hope. It's still open now, but thankfully the census is down, and so, but it remains open because we know that this pandemic is not over. But one of the things that we found initially, one of the things that I started to notice at the beginning was that there was not data coming out from the city or from the state about who was getting tested, what the results were, who were the people who were getting affected the most in this pandemic. And what we found is that and the data that we were collecting in the program was there was not consistency in that. And a lot of the data that we ended up getting as far as who was tested and who was not tested ended up coming from the labs that we would send the test to, and then we were sort of depending on the information from that data early on. We did eventually start to get that data, and the data started to be collected, but even within the city of Boston and in the state of Massachusetts, until all of the other data from some other states that were getting hard hit started to show up, we were like many other states where there was a huge chunk of the data missing. So there's about, I think the data is about a third incomplete, or two-thirds incomplete of the data that is available for Massachusetts, because it just was not being collected at the very beginning. So the slide just went away, and it says share my screen, and I have something with a little musical note on there.
We'll fix it. One moment, please.
Sure.
There
we go. Thank you. But one of the things that we started to realize early on when the COVID care spots were set up, it came to my attention that limited English proficiency folks there was not access for them in the tents, in the temporary spaces, so that they could access care in the same way that native English speakers could. And so one of the things that we did early on is we made sure to order some dedicated phones, iPhones, et cetera, that could go in the spots that were dedicated, that were to be used strictly for interpreter services. We then made some, informational cards so that everybody could be encouraged to use interpreter services instead of trying to wing it when, they weren't proficient in another language, which, we want to make sure that we discourage for sure. And made sure that those things were posted around. And so that we had the extra resources, we had these extra phones, we had these extra resources that we focused on and put those in a lot of the COVID sites. And that ended up working really well. One of the other things that I heard that was happening is, when folks are in full PPE, they're kind of looking like, space explorers or beekeepers or something like that. And we got reports that this is very intimidating and frightening to some patients. When they were coming in, they're being tested and then being told that they had to go into isolation. And so somebody found an idea that had actually started during the Ebola crisis in Africa, where people made name tags with their pictures on them that show what they look like without the full PPE. And we laminated those and put them so that folks who wanted to could wear them on their PPE so that it would add a more personal touch and it wouldn't be as frightening and intimidating to people when they were coming in for COVID care. There were some folks, and this is not coordinated through any coordinated effort except for a group of folks who decided at Health Care for the Homeless program to do some advocacy on their own around decarceration. And there was a group of folks, and they could still continue to do it, that worked on lobbying the local jails and prisons to get some people who are incarcerated released because we know that COVID was spreading pretty quickly there also. One other thing that we did, with Dr. Jen Brody, who heads up our HIV team, and the two of us did a webinar together on COVID-19 and structural vulnerability that we presented to fourth-year medical students who were practicing pretty much throughout the Brigham and Women Partners healthcare system. And so that we wanted to make sure that the students and the med students and the future doctors had some sort of knowledge and awareness about these structural issues because they were the ones who would be going to take these issues forward. Dr. Brody teaches them a course during the year, and I'm blanking on the name of it, but it has to do with structural racism and eliminating structural racism. Let's see. One other thing that we did, and this was the brainchild of Phil Sango, who is who's the co-chair of our Equity and Social Justice Committee, is to start a mutual aid fund for staff. And this was something that would be available to anybody who's a staff member because we knew that some people did have to do furloughs, even though we did fewer than 10 in the whole program. Some people did get furloughed early on. And we also realized that even if people were not furloughed from our program, they still had family members who had lost income. And so Phil thought of this idea to create this mutual aid fund where we would have a very low threshold and funds could be available for any staff member who applied. Staff was able to donate if they were able to. If people wanted to contribute to the fund, they could do it out of their paycheck. They could ask for payroll deduction. And the program, the Health Care for the Homeless program, started off by contributing a huge amount to get us started at the very beginning. So we set aside $10,000 was the initial contribution from the program, and then we ended up getting an additional, another good amount for this to be used. And so this has been an ongoing thing, and folks, I think, have been finding it helpful. Some of you probably have heard discussions in your state about the critical standards of care that have been circulating, and those are the standards which will determine if a hospital system becomes overwhelmed, who resources will go to, who will get a ventilator, who will get critical life-saving care. And there is a formula that figures all of that stuff out. And even though in many states there's this proclamation that race is not to be taken into account, what we found when it came to the one in Massachusetts is that even though they say race is not taken into account, the way that the metrics were calculated and the way that you got a score to determine your eligibility had a very detrimental impact on people of color, because one of the standards that they were using was your mortality likelihood. We all know that in this pandemic, this is something that was particularly Black and Brown and Indigenous folks very, very hard. And luckily, there was a channel that there was a lot of uproar in the city, and one of our blood members, Dr. Thea James, was able to run into a panel, and they modified the standards to so that it was it changed the equitable nature of it. And in the state of Massachusetts, there was a panel that was just recently put together that met last week, which is it's called the Health Equity Advisory Group, and our medical director is a part of the Health Equity Advisory Group to look at how standards and practices and, how we can take advantage of this moment and join with other folks to make sure that we don't go back to where we were before, when we were having, the root causes of these disastrous results of the COVID-19. So I'll stop here because I feel like I'm talking a lot, but happy to answer questions at the end.
Thank you, Sonia. I know that it was difficult to hear some of that, but I was able to understand at least. So we've got two more communities to hear from, so I'll turn it over. Renata, Chantel, I don't know which one of you who's going first, but I'll go ahead and put up this slide for you.
Thank you so much, Michael. Really appreciate it. Really appreciate being here. We, Renata and I, have decided we will keep it short and sweet because a lot of the things that Tanya and Sonia have mentioned are some of the things that we've been doing at the Colorado Coalition for the Homeless. I will start with talking about us as an agency. So we are an integrated housing, healthcare, and supportive services. And so we do a number of things over at the coalition. One of the questions you asked to prepare us for this conversation is around racial justice, and how do you ensure that racial justice is the lens in which you're operating from as you're making decisions. And I think that has been really important for Renata and I as we are pushing folks that we work really closely with to think in that way. What we knew to be true prior to this pandemic is the population that we serve were disproportionately African American and Black folks and Indigenous folks. And it would have been irresponsible for us not to think about those folks and center their experiences in any decisions that we were looking to move forward. And so on this slide it says racism within our culture. I think one thing that I wanted to talk about here, because I think it's important, is when you think about a pandemic, you think about urgency and the importance of naming urgency and quality over quantity as one of the things that perpetuates white supremacy within your cultures. And so it was important for us to take a step back. While we wanted to move quickly and make decisions quickly, we also wanted to make sure that we were doing with people and not doing to people, and that the folks who were going to have to carry the burdens of our decisions were a part of decision making, right? And that was really, really important for us. I think Tanya and Sonia may have mentioned the importance of taking care of your staff during this pandemic, and that has been supremely important to Renata and I, and she will talk about it from the lens of PPE. But even when we talk about testing and who has access to testing and who doesn't, I think that is also about self-care. So I will just rattle off a few things that I think we, in terms of being proactive, that we were able to do over at the coalition. Not perfect in any way, lots more to do, but I think a good start for sure. So it pretty instantly implemented teleworking, so making sure that folks who could work from home have access to do so. We have now enhanced pay for our employees, and so along with pandemic leave, in case folks do get sick, we aren't asking them to risk their lives for their livelihoods, because who wants to be the folks who are doing that? That's not cool. We talk about radical self-care, and so if you know that term, you know the importance of that term and where that comes from around radical self-care, and we thought that was really important. We really felt it to be important to communicate proactively with our staff about what was going on, and so we have bi-weekly town halls that happen over Zoom, which has actually been incredible for us because we have so many folks at different sites and locations. It's something that we've talked about continuing past the pandemic because it's been a way for us to connect. We have hero awards where we're just celebrating folks, and folks within our agency are celebrating one another and saying, hey, I see you doing an incredible job. I just want to shout you out. Those are attached to gift cards. But also we shout folks out within our town hall to just let them know we appreciate you, we love you, we support you, and we're thinking about you, and we really appreciate the work you're doing for us. And then we have daily updates as well that are going out to our staff. We had originally had those from Monday through Saturday, and we realized people were pretty burned out and weren't really reading them on Saturdays anyway, and so Monday through Friday probably made the most sense. So I promised that I would keep it brief, but just kind of wanted to talk about, you know, how we want to rush to make decisions, and during a pandemic we might want to slow down to really think about the folks who are burdened by those decisions. Renata?
Yeah, thank you, Chantel. You summed that up so well. Like all my notes on my paper, you said most of. So I'll keep it short as well and just add one piece from a leadership capacity internally. Chantel said it best. We've been doing a lot of pushing, but one thing that's been great is our FAIR CEO really understands these systemic issues, and he's actually grasped that moment by saying, listen, what can we do that would be long-term, which is basically having more housing for our the people that we serve. And so we have really partnered with our community really well. We have a lot of hotels where people are staying in, and we're really looking at longevity, like how do we have more respite care? How are we doing more of these services? Because what I hate hearing is people saying, let's go back to normal, when normal is not where we should go. We should go forward with a change and making sure that we are embracing all these gaps that we see and moving forward. So the last thing I'll touch on briefly is healthcare and the choices that we're even making right now in our systems. So when you think about what's happening in our world, whether that's our staff or the people we're serving, if people are getting sick and going to hospitals and those hospitals are overflowing, they're making choices to save lives of those people that don't have underlying conditions. What does that look like for people of color? Because most people of color have underlying conditions. Why? Because of systemic issues that are embedded within that when you talk about social, economic class, redlining, where you live, your education, what foods you have, access. So access must change. So with all those things that we see, we're trying to make changes and making sure we're having housing longevity, because if people have somewhere to stay, then they can socially distance themselves. They can actually be healthy, then also moving into other areas. So I will just sum that up and say, Chantel said all the other staff thing. I'm an HR person, so it's all about the staff anyways, but those are the things that we're doing. Thanks.
Thank you so much, Renata and Chantel. Really appreciate you guys. So we'll hear from Albuquerque next. Linda. Oh, you may still be on mute.
Sorry about that.
Nailed it.
Hold on a second.
This is usually a case of mute the computer speakers and then unmute your phone. Oh, she's hearing through the computer. So I'm still not hearing you, Linda. I think it's you should be speaking into the phone and then muting your computer.
Hold on.
We can hear you now.
Wait, can you hear me?
Yes.
Oh, okay. Sorry about that. Well, I want to thank Bobby and Michael for inviting me to be a part of this panel today. My name is Linda Stone. I'm the Director of First Nations Community Health Source, and we are New Mexico's Urban Indian Health Center. We're also one of 44 urban health programs nationwide. And in addition to providing many of the same services that a lot of the healthcare for the homeless clinics provide, we also have a cultural wellness and traditional healing services program that addresses the cultural and spiritual needs of the urban Indians that we serve, which is really vital for achieving positive health outcomes. We've been around for 48 years, and we're located in an area within Albuquerque that has the largest concentration of Native Americans. Native Americans make up about 40% of our patient population, and we serve individuals from the Navajo Nation, New Mexico's 19 Pueblos and Apache tribes, as well as many from out of state, including Oklahoma, North Dakota, Wyoming, Minnesota, and even Canada. It's estimated that between 25,000, according to the U.S. Census, to 55,000 urban Indians live in Albuquerque. And the city, Albuquerque, is among the top 5 urban areas with the largest concentration of Native Americans in the country. And then just a little bit of information in terms of Native Americans, because I think it's important to understand this, is that in New Mexico they have the most severe socioeconomic disparities. They have the highest rates of death from diabetes, cardiovascular disease, suicide, and substance abuse. And they're also disproportionately represented in the homeless population in the city. It's estimated they make up between 35 to 40% of the homeless, whereas they make up 9% of the city's total population. So in terms of understanding the racial disparities on my slide, they are interrelated, but I would like to just provide some historical context to understanding the health inequities experienced by Native Americans and the years of historical trauma that has impacted their health status. So the creation of the reservations was a concept developed and imposed by the United States federal government to force Native Americans from their homelands to make way for the settlers. Many aspects of their cultural and traditional lifestyles were further destroyed throughout the history, including when they were forced to attend non-Native boarding schools, and then also later forced to give up their children through the forced adoptions to non-Native families. Despite making promises to provide them with quality health and education, Congress has long failed to live up to these promises, and even today this is apparent in the COVID-19 pandemic. The Navajo Nation has the second highest per capita rate of COVID-19 cases in the country. And the federal government has failed to adequately fund Indian health services. The urban Indian health funding has always remained at 1% of the total IHS funding, even though 70% of Native Americans live in urban areas and not on the reservation. The U.S. Commission on Civil Rights conducted a study in 2003 and reported the funding levels for Native Americans was way inadequate despite the federal government's obligation to provide education, public safety, health care, and other services through treaties, laws, and other acts. And the net result is the inadequate funding of their health care directly impacts the types and quality of services, including health education, disease prevention, and is a main contributor to their health inequities and poorer health status, again, as evident in the COVID-19 pandemic. The average lifespan for Native Americans is 5 years shorter than for all other races, and they have a higher mortality rate from preventable diseases like diabetes, cirrhosis, cardiovascular disease. The Indian Health Services provides care to over 22 million Native Americans from 560 federally recognized tribes across the country, but the underfunding has severely limited the quantity and quality of services offered and inadvertently contributed to the poorer status, including their high risk for COVID-19. The tribal members receive a different health care reality than many United States citizens. For example, to match the level of care provided to federal prisoners, IHS funding would have to nearly double, according to the National Congress of American Indians. And to match the level of care provided by Medicaid benefits, IHS funding would need to more than double. The scale of the healthcare crisis that has existed among Native Americans has expanded significantly given the population growth among Native Americans, the inability of the healthcare funding to keep pace, and now the onset of the COVID-19 pandemic. They experience higher mortality rates due to high rates of pre-existing conditions and lower access to care. And as with other crises that they've had to endure, such as their suicide epidemics, violence against women, and climate change, many Native American communities feel that they are left to manage the COVID-19 crisis by using their own resources, including their culture and family. But even implementing traditional practices has become a challenge during COVID-19. Stigma, systemic inequalities undermine the COVID-19 prevention efforts and increase levels of chronic stress and ultimately sustain the existing health and healthcare disparities that have existed for years. In terms of the things that First Nations has been doing relating to diversity, equity, and inclusion, before COVID, we implemented several practices such as trying to instill an inclusive culture through education, recruitment, employee development, and collaboration on diversity-related initiatives. We also require all of our staff to participate in a cultural humility training to increase their sensitivity and understanding of diverse groups and institutional and personal biases. We also form ad hoc committees that look at our procedures and policies so we can look inward and see where we need to improve to be more inclusive and more equitable. And we have a homeless advisory committee, and we just formed an LGBTQ sensitivity committee to do that. We use a patient-centered approach that's focused on health and wellness and our patients' needs, and we work to address health disparities experienced by the urban Indian community through integrating care to address the whole person and create and implement programs that are specifically dedicated to address their social determinants of health. And then post-COVID, we did many of the things that many of our speakers have already mentioned in terms of protecting our staff and ensuring their wellness, including equipping them with PPE and offering them with COVID-19 testing. Our behavioral health services offers a noontime COVID-19 mindfulness session for all staff, and our Chief Medical Officer regularly conducts COVID-19 presentations to our staff to provide them with updates. We also expanded our services to include COVID-19 activities targeting urban Indians and individuals experiencing homelessness. We provide COVID-19 education that incorporates cultural elements and hosted an urban Indian COVID-19 testing event. We've also installed hand washing stations and outdoor restrooms and provide curbside and home delivery services, as well as home visits for individuals who are recently housed, as well as try to place individuals into housing and motels, distribute PPEs such as cloth masks, and we just started implementing telecultural services and telebehavioral health services. And so I think, as Michael mentioned at the beginning, the COVID-19 has exposed and amplified many of the health disparities, namely the communities with the highest health disparities are most impacted. And one of the things we know about the Native community that we serve is their fears and concerns about being stigmatized, about having high rates of COVID-19. And we saw this in the Native communities with HIV. There were fears and concerns of being stigmatized about HIV, which prevented many Native Americans from being tested or getting help, and inadvertently contributed to increases in HIV transmission rates. We're aware that that the Native community is just as sensitive about COVID-19, and we make sure that our procedures and delivery of services are sensitive to honoring their concerns about the stigma and confidentiality to facilitate high trust levels and retain and engage our patients in care. Thank you.
Thank you so much, Linda and everyone. I've learned a lot in the 55 minutes we've had together, and I'm grateful for all of the work that you're doing. It's clear that you're all committed to this work, and sometimes having to push other people to get more committed. So really appreciate you. We have just 5 more minutes total, so I think maybe let's just have each of us respond to a single question to close us out. And this is one that was sort of articulated in the chat box here, and I encourage all of you to use that chat box to tell us what you've been doing at your organization as it relates to racial justice. But it seems to me that we have different roles to play as individuals within organizations based on our racial identities, based on where we are in the hierarchy. If you could talk about what you see from that lens, how are our roles different, and then what do you recommend for folks who are kind of maybe lower within the hierarchy at their organizations? So I'll just go in the order in which you're appearing on my screen. Chantel, do you have any thoughts about that?
Yeah, thank you so much. I always encourage folks to do some exploration as an individual around anti-racism and anti-racist response. I think it's important for you to know what that looks like within your culture, within your agencies, and I think you do that by learning. I'm happy to put into the chat room some resources that I've used, some readings that folks can use as a starting point. I would also encourage you to find folks who might be in the same spot as you, right, like in terms of hierarchy, who you can have discussions with. And also, don't be afraid to create what's not there. So over at the Coalition, we have an Equity, Inclusion, and Diversity Council. I would encourage other folks to have something similar to that, so you have a coalition of folks who can work on some of these issues with you. And finally, I'm done after this, I promise. Don't be afraid to call folks in when you are seeing things that aren't an anti-racist response, and have conversations with folks and say, hey, this is what I experienced in that moment. Can we talk about it? They're hard, but absolutely necessary. That's it.
Thanks, Chantel. Do others of you want to add on to that? Sonia?
I'll say just really quickly, it doesn't matter, and I know the question in the chat is, depending on what role you are in the organization or in your program, there will always be like-minded folks that you can connect with. I think this is a wonderful opportunity for us now that the inequities of COVID-19 have shown up so clearly. This is an opportunity for us to really join forces with other like-minded people and do something that you feel comfortable with. Educate yourself, but join if you have a DEI committee or an Equity and Social Justice committee. Go to it, check it out, get the conversation going, educate yourself, but don't let this moment pass. I think this is an incredible opportunity, again, for us to hopefully move the needle towards equity.
Don't let this moment pass. Well said. Linda, Tanya, or Renata, anything more to say before we sign off?
I would just add, Chantel, pretty much, we talk all the time, so we think a lot alike, but I do think it's important for you to create allyship, find out who those people are, because this work is hard, it's challenging, and you're going to need time and space. We talk about radical self-care and resiliency. When you really get to the nitty-gritty and find out what's happening, because sometimes you don't even know as a brown person or a black person what's happening to you, but once you start to recognize that, it's important to have allyship so you can talk about it and create space to come up with solutions. But the pain is real, so you do need a source, so create those layers for yourself. Definitely get you a coalition of people that are going to help you go forward. That's so important. So that committee is really important.
I agree with everything that's been said so far.
Great. Okay, well, we are almost at the hour, and I know that we maybe created more questions than we answered because of the nature of this work. I encourage you to stay in touch with us. We are committed to pursuing racial justice in all of our work here at the Council, and we have a lot more to do, and we encourage your feedback in that regard. I put some resources on the slide here, and I encourage you to continue to watch our coffee chats Tuesdays and Fridays. We also have an anti-racism resource page on our website, which is really a culmination of our learning collaboratives and the work that we've done there. So with that, I want to thank our panelists. Good grief, I love you guys. And thank you all for attending today. And I really just appreciate the work that you're doing. And I hope that you take some time for yourselves and prioritize your health. So thank you.
Thank you.